Welcome to Mid Delta Community Consortium. We are based in Phillips County, Arkansas, which is in in the community of Helena, West Helena. And we are a nonprofit that I serve as the project director / director of. I want to tell you a little bit about who I am and how I got to this place. My name is Huff. And some people who may be watching this may have known me as Annie at one point in time. Mid Delta Community Consortium, which I'm going to refer to as MDCC, was created back in 2001 through the College of Public Health to basically apply for some funds that would be directed or channeled across the Delta, the Mississippi River Delta. Through that organization, federal dollars were funded into the Delta to work with organizations, agencies, entities located in 38 counties. And our charge, or MDCC's charge, was to create what we call local health networks. And across those 38 counties, that meant that we had to go in and partner with or help to create these partnerships that were going to work toward bettering health or increasing capacity of organizations to engage in health education, health prevention, health, all the things that go with health and wellness.
Tell us a little bit about the environment in which you developed those networks. This 38 counties, how would you describe it?
I guess my basic description of the 38 county region that we were working in, or that we were charged to work in. First of all, I want to mention that those 38 counties were not counties that we selected. Those were counties that were identified by the federal government. The funding source is out of Health and Human Services, the Office of Rural Health Policy, Health Resources Services Administration. I know that's a lot, but that's who the funding is channeled through. And they made the designation based on some previous work that had been done. And so these were the 38 counties that were considered Delta counties in the state of Arkansas. I also want to give a little bit of background about this particular Delta state initiative that we were a part of. Arkansas is only one of 8 states that's a part of this initiative. So along with Arkansas, there were 7 other states who were engaging in very similar activities. And what we were charged with doing was setting up these rural health networks. And the way that we decided, MDCC decided that we would go about this work, is to go to those respective communities, identify stakeholders or gatekeepers in those communities, and let them decide who they would bring to the table. Now, what our role was going to be in this was to try and make sure that there was diversity in those folks who were going to be a part of the partnership, that there was inclusivity, which meant not only were they going to be diverse, whether it was ethnically diverse or economically diverse, but that all folks who were a part of that community would be engaged in the conversation as to how they were going to deal with health and wellness in their respective communities. So that meant that once we got into the communities, we found that there were people who were doing all sorts of things, but they didn't know what the other person was doing. So we decided that we were going to try and help them pull these folks together, bring them to the table, and boy, was that a challenge. We found that there were folks who were working on some of the same ideas or had some of the same issues that had never even talked to each other before. We found that there was so much turfism and so much territorialism that we started asking the question, can we do this work? County judges were not accustomed to talking to county judges. Hospital administrators weren't accustomed to talking to hospital administrators, even in the same counties sometimes. So this was really interesting. So HRSA, they went into a contract with the Georgia Health Policy Center to help those Delta State grantees to work with those respective communities, because we didn't have the expertise to figure out how do we go in and try and prepare these folks to have these conversations with each other. And what we were going to do, we were going to provide them with some resources, some financial resources, also some technical resources to help them facilitate these conversations around what are you going to do with the resources that we can provide you with. This was a very interesting time. 38 counties, very different counties. Most of those counties are based on the Mississippi, they border the Mississippi River. The demographics are primarily African American, but most of the persons who are the power brokers are not African American. They are folks who are Caucasian. They're the hospital administrators, the health department administrators, the local health care facilities such as the community health centers, the free clinics, all of those, physician's office. Most of those were not under the charge of African Americans. So we had a really significant challenge ahead of us.
And so how many partnerships or networks were you able to develop, and how were, I assume some of them were very successful. Tell us something about what success you faced.
We have been engaged in this work now since 2001 through the HRSA funding. During that first initial year, and this funding came in rounds of 3-year funding, so it wasn't just 1 year of funding and then you had to figure out, where the subsequent funding was coming from. We were always operating under the knowledge that we knew we had 3 years of funding to work with at this particular point in time. Not that we never knew that we would still be in this up until this point. But what we did was, that first year we initially ended up with, I don't think that those folks that we were working with at the College of Public Health ever thought that we would move as rapidly as we did. During the first year, we ended up with, if I'm not mistaken, 7 to 9 networks. Now, to me, that was not success at all, because I've always been one of these folks who believe that if you're charged with doing something, you put your whole effort toward that and you achieve that goal. I was wanting all 38 counties to be engaged in a network during at least the first 2 years of funding. Boy, did I have a lesson to learn. We engaged during the first 2 years, 26 of those 38 counties. And I would say that those 26 counties were very aggressive in their goals, what they wanted to do. Because simultaneously, as we were doing this work, the governor at that time had mandated that each county create what's called hometown health improvement coalitions. So the health department had this mandate, but they didn't have the resources to do a lot of this work. Well, we came on the scene with these resources, but we were seen as an entity that was going to be in opposition or in competition with what they were doing. Well, my first challenge was to convince those health department administrators that we're here to help you do what you need to do. When they finally realized that and realized we had this money, it formed a partnership that has been a lasting partnership to this day.